All right, well, we will go ahead and get started. I see there's still people trying to connect, so we will just let people connect as they can. Good morning. My name's Kelly Spar, and I'm the president of the Nebraska Culture Change Coalition. We are really excited to have you all here this morning for our Coffee with the Coalition. This is something that we do monthly. We bring you guys an education, free education for you. It's also recorded, so if you have to hop off or if there's somebody you would really like to share this with, we will send it out to you right after this session so that you guys can listen to it again, share it with others, whatever you need to do. So, having said that, this is Dr. Sarah Griess. She is not only my sister, but a licensed psychologist who specializes in working with adult individuals who have had traumatic experiences. She also provides mental health consultations to organizations and presents through the state on different aspects of trauma, relationships, mental health, and overall wellness. So welcome, Sarah. We're glad to have you here today, and I will let you take this over.
All right, thank you. Thanks all for being here. I do know that some of you may need to hop off. Life doesn't stop just because we're having coffee and conversation. So if you need to hop off, that's fine. There is, Kelly, you all had posted the access to the PowerPoint, I think, on the coalition website. Is that accurate? Okay, so if you're wanting a copy of the PowerPoint just for your own notes or later reference, that is on the coalition website. And then as Kelly mentioned, there's a eval link in the chat that if you could complete that by Friday, that would be wonderful. Not only does that give us feedback in helping to fine-tune our continuing education, but it also helps with funding for things like these. There is grant money in the state of Nebraska so that these can be offered for no cost to organizations such as the coalition. And so that does help with that grant process. So I was telling Kelly earlier, I could talk about this for hours. It's one of my favorite things to talk about, especially now because it's so prevalent. We're seeing a lot of research on the issue of burnout and compassion fatigue. It's one of the most highly requested presentations that I get. And oftentimes, I mean, there's just so much information. So the PowerPoint does have some information that we're not going to have time to cover today, but I wanted you to at least have access to all of the information. So that will be on there, and you'll see that we'll fly through a few of these slides just to get to the meat and potatoes of compassion fatigue. If you have questions, feel free to put them in the chat or hang on to them till the end, and we'll have time to look at them at that point. Or if something just really isn't like, it's just not resonating, go ahead and you're welcome to also ask as we go along. So we will just dive in and get started. I'm going to talk to you for just a second about the ProQual, which is a professional quality of life measure. We're going to just real quickly review some definitions of what we're talking about today. We're going to deep dive into exactly what compassion fatigue looks like, possibly for all of you, and then look at some skills for either intervention if you're already in compassion fatigue, or prevention if you're not there yet. So hopefully that you won't get there. This website up at the top, proqual.org, I do encourage all of you to go to that. They actually have a symptom survey, if you will, that you can fill out, and it will print out a report for you in terms of where you're at in regards to your own compassion fatigue. Do you have symptoms of burnout? Do you have compassion fatigue? Where are you in compassion satisfaction? And it gives you a whole bunch of feedback. Plus, that website has a ton of really, really good resources. If after today's presentation you find that, oh gosh, I'm really in this space, that's a really great place to start in terms of just educating yourself about what compassion fatigue is, and some really practical tools that you'll see some of today, but there's a greater resource bank on that website. So We're going to talk about compassion satisfaction, which is the feel goods that we get from our jobs. This is, when you have a positive outcome and you leave working with somebody and you just feel good. It's the helper warm fuzzies. Compassion satisfaction is really, really important for us to continue in our job. These are the positive outcomes that keep driving us to do the work that we do. Burnout is probably not a new term for most of you. It's the physical and emotional exhaustion that comes with either low job satisfaction. So you're working, and there's not a whole lot of outcomes. Maybe you're running up against system limitations, the motivation of the patients that you're working with, family dynamics. There's a ton of things that we run into that are barriers in this work that leave us feeling powerless, helpless. Why am I doing this? What other job can I possibly get that doesn't suck so much of my energy, that comes with those negative outcomes? Signs and symptoms of burnout, and then we'll kind of compare that to compassion fatigue, actually resembles depression. A lot of people will come into therapy for depression, and what we find out is that a lot of it can be job related, particularly in health professions. We are seeing just a ton of this, not only post-COVID, but there's a lot that's happened in the last 3, 4, 5 years, politically, socioeconomically, health-wise, people having access to resources that really puts a burden on the health professionals and changes the way that you engage in the profession. And so these are some of the signs and symptoms that may say, hey, you're starting to move into burnout, feeling exhausted, not having a whole lot of motivation to do your job. Maybe you're getting sick a lot, starting to have a negative, cynical, or pessimistic attitude. We start, kind of being sarcastic and making some sarcastic jokes, which turns into dread of going to my job or dread of serving particular patients. We start to wonder, are we even really connected to our colleagues? Are they working as hard as us? Do they care? Are they as passionate enough? And it can start disrupting collegial interactions. Attendance goes down, productivity and how effective we are in our jobs goes down. You start to isolate, and you just don't have the skills and resources to manage the stress that comes with your job. So that's a little bit of what burnout looks like. It's just that mental, physical exhaustion and dread in going into work and doing the job that you probably went into once because you love it and you're really passionate about it. Vicarious or secondary trauma is when we start having trauma reactions to things that are not our primary exposed trauma. So we witness something somebody else is going through, we witness somebody else's trauma, or hear about or see the repercussions of that trauma. This is when the suffering of another person begins to impact our inner experience. It starts to change our beliefs about ourselves, others, and the world. For example, if you're working with a client or a patient and you are working really, really hard to get them connected to all of the resources, maybe some of it is just meeting basic needs, financial security, housing security, food security, and you're constantly running up against system regulations, or maybe it's a patient who falls in the gap of what they qualify for, and that constant running into that and seeing the negative impact of this person who's suffering because they can't get the services they need starts to impact our inner beliefs. What kind of world is this? What kind of profession am I in? Why am I even doing this work? Are people even trustworthy? Am I ever even going to make a difference? And it starts to change the way that we believe about ourselves and others. Whoops, I'm going the wrong way. Sorry about that. Enter in compassion fatigue. Some of the research actually interchanges compassion fatigue with secondary or vicarious trauma. They use them as the same concept. Some of the research actually separates vicarious trauma and compassion fatigue and talks about it as the physical and mental erosion, the wearing away of our own internal resources after doing work that requires a lot of compassion and empathy from us. In the healthcare profession, there are some ways in which you learn, right, to detach emotionally so that you can objectively and effectively serve your patients. There are also some times where it's really hard for us to do that. And you can't be robots in your job, right? Or you're not going to have a lot of positive outcomes because people want that bedside manner. They want that relational connection from their service providers. And when we engage in that relational connection and we're running up against constant stressors that are outside of our control, it starts to wear away our internal ability to engage in the way that we want to. Signs and symptoms of compassion fatigue look really, really similar to burnout. Physical, emotional, behavioral, work-related, they all really resemble burnout, except it starts to impact, again, those internal beliefs, the spiritual beliefs, the meaning of life beliefs, because it really starts to change the way we see the world and others. And we'll come back to this in just a second. So that's a very short cut and dry of what this is looking like, right? If you're going to work, you're starting to have dread, disconnect from your colleagues, starting to question, why the heck are you in this field? Why do you do this work? Feeling exhausted instead of replenished, running into barrier after barrier, lots of negative outcomes. You are probably either in compassion fatigue or you're at risk for moving from burnout into compassion fatigue. So why do we care? Back to this signs and symptoms. If you look at this work-related column, okay, think of a particular patient or patient setting that you work in. And I want you to ask yourself, what would happen with that patient or that particular setting if I started avoiding or dreading working with my colleagues? If I didn't ask for help when I needed it, if I didn't consult when I wasn't sure about things, if I actively had to expend energy avoiding running into other people, what would happen with that patient or that patient setting if I wasn't able to have empathy? If I was irritated and why can't they help themselves? Why can't they do this themselves? Why can't the family step in? Why can't somebody else do this? Engaging in kind of a more cold or disconnected manner, calling in sick. What would happen for your patient if you were calling in sick a lot because you were burnt out or had compassion fatigue? What would it be like? And maybe some of you are in this space if you went to work every day and didn't have any warm fuzzies, any of that compassion satisfaction. What would happen if you started making clinical mistakes in their care? You started being less productive. Okay, that's why we care about compassion fatigue. Sorry, my switcher is really sensitive here. But that's why we care about compassion fatigue, and that's why we really need to start talking about it. Is people find themselves in these spaces and they think, oh my gosh, it'll go away. I just have to push through it, push through it, push through it. But if we don't stop and see the big impacts of what's happening to us, then it starts to trickle out and impact our patients. And then what happens is when we are having all of these non-empathetic clinical mistakes in care situations, then the patient is not satisfied, which then we have more negative outcomes and it starts to have a snowball effect on us. Empathy has a huge role in compassion fatigue. We are probably, most of us, in the health professions because we have care and compassion for others. We use empathy in our jobs. Empathy, the description of that is the action of understanding, being aware, being sensitive to the feelings and thoughts of others. Without, right, healthy empathy is without actually absorbing those as our own, and sometimes even without those thoughts, feelings of the patient having to be communicated to us. We can look at a patient and say, gosh, it must be so hard, right, to be in a place where you don't qualify for this service, but this is what you need, and have, you know, X, Y, and Z physical effects because of that. The patient doesn't have to say it's hard. They don't have to say they're hurting. We can observe that simply through empathetic processes. Empathy can occur as conscious and intentional, so something we purposefully apply in our jobs. And it can also occur as unconscious and unintentional, which is where we get into trouble and where we fall into compassion fatigue. Conscious empathy allows us to sit with the individuals, right? Intentionally apply the skill to understand how the person must feel. We love when others exert empathy to us, and I'm going to guess your patients love when you exert empathy to them, because we like to be seen, we like to be heard, we like to know that people care about us, right? And empathy is one of the ways that we connect with others. Unconscious empathy occurs when we are accidentally starting to absorb the emotional state of someone or something else. I'll give you an example. Have you ever gone to work, been in a meeting, spent some time around an individual who is just a crab? They're in a bad mood, they're being crabby towards everybody else, and you walk out of that experience being like, ugh, now I'm crabby, right? That is an unintentional absorbing of the emotional state of someone else. It's also an empathetic process, but it's an unconscious one. We do the same things with our patients. So where does unconscious empathy occur? We hear stories. Your patients, I imagine, tell stories, probably not only about why they're in the situation that they're in or how they're in the situation that they're in, but patients love to tell stories about their life, their childhood, their family. A lot of older individuals will like to tell stories about how somebody's done them wrong. Right? Very justice oriented sometimes, but we hear these stories and sometimes they're fun and funny and uplifting, and they're really just connecting because we're giggling and we're enjoying and we're, learning about the patient. Sometimes they tell us stories that are really, really hard to hear. Sometimes they tell us stories about abuse, family members taking advantage of them, stories about being lonely, stories about hardship, about relationship disruption, about being depressed or suicidal. Those things that we hear, right, start to wear on us. They start to get heavy for us if we don't have an awareness and take care of them. We also see things. We see people struggle. We see them run up against system barriers constantly. We see them struggle in chronic health and pain conditions. And to see that struggle day after day, unless there's positive outcomes and positive experience to offset it, again, this is another heavy piece of the work that you carry. Sometimes we see interactions with family members who are struggling. If you've been with a patient who has passed and their family members are around and you see the devastation, or you see a family member feeling really helpless because their parent won't choose to take care of themselves or won't make choices that change their situation, and it's devastating the family. That's really hard. I think on Netflix, there's a documentary called Hoarders, and I think naturally it is a curious something for me to watch as a psychologist, but you can see, right, if you've ever seen a documentary like that, the impact on the family of how their family member is living. And then, as I've mentioned several times, because I imagine most of us can resonate with this, seeing the impacts of barriers in systems, and that can feel really, really helpless for us in knowing that there's not a whole lot that we can do, no matter who we call, how we press, no matter what we think needs to happen. Sometimes systems have regulations or loads that don't allow them to attend to the patient needs as you may see they need to be attended to. The other thing that happens for us is emotional infection. And we're going to just watch a quick clip here. Hopefully, I tested it out earlier of what I'm talking about. So just watch this clip and pay attention here. I want to make sure my sound is good. Okay. And just notice how you feel as you're watching this.
Oh no.
Okay. Well, I got to get it stopped here.
I didn't want you to stop playing it, honestly. I was laughing so
Good. You are a prime example then of what I'm trying to show, which is that emotional infection. An emotional infection is a really positive and can be a very powerful tool. We can see it on the flip side if you watch like the Sarah McLachlan animal treatment commercials that come on, and they play that Arms of the Angel song, and they show the dogs who are starving and beaten and abused, and your heart goes out and you want to donate money. Like, this is a real concept, right, that people use in marketing, and also happens in human interactions, is that when someone is experiencing something, it is infectious. If I was sitting here talking like this and very monotone and had no energy during this whole presentation, right, you all would probably start to sit back and get bored and tune out. Emotional infection is a thing, and we need to be aware of it, because sometimes it's really positive, but when we are in jobs, right, where we are navigating other people's dynamics and system dynamics all the time, it becomes really important for us to understand how emotional infection works. So over here on the top left, we have our care for an individual. Maybe we're hearing a story. Maybe we're seeing a struggle. Maybe we're seeing the impacts of a recent injury or illness on the person, and we are actively involved in either being in relationship with that person and hearing their story, or even treating, right, the impacts of whatever's happened for them. We start to have emotional infection. Okay, when somebody is sad, upset, mad, we start to feel that, right? When we do this and we start making faces, okay, if you think of your empathetic face, somebody's telling you a story, and you start furrowing your brow and your mouth turns down, you can feel physical changes in your body, right? Just like you said, I didn't want you to stop playing that video. I was laughing. You can feel physical changes when you have that smile on your face and you're engaged in something joyful. So when we have these facial responses, okay, what happens is then it sends messages to our brain. There's muscle memory and there's connection between this, right? If you, after this, sit there and just put a mad face on for a minute, you're going to start noticing changes, because your muscles in that mad face send messages to your brain that, oh man, something must be going on, okay? And then we start creating a narrative in our head. For some people, it involves words. For some people, as they're hearing the patient's story, they're creating pictures or sounds in their mind, right? To see the story, hear the situation, and then our brain picks up on that. And our brain isn't always really good about differentiating what is ours and what is somebody else's. So then what does it do? Well, we start feeling that emotion, and it's sending messages throughout our body to respond to an emotion that we are absorbing from somebody else, but we respond as if it's ours, and that's unconscious empathy. And if that is happening day after day after day, what happens is our bodies and our minds start having a huge toll taken upon them, and they start responding by burnout and compassion fatigue symptoms. quick case example, and I'll just read through this, but I want you to get an idea of what this might look like. So Miriam, who is the health provider, had been providing in-home care for an older patient, Lucinda, who had very few familial and social supports. Lucinda's daughter was the one who manages her finances and was in charge of helping to make decisions for Lucinda regarding healthcare, housing, etc. Lucinda's daughter lived in a different state, and they were not close in their relationship. Miriam, again, the healthcare worker, had been attempting to contact Lucinda's daughter to discuss some concerns regarding general maintenance of Lucinda's home. Lucinda was still able to physically manage general cleaning of her house, but she wasn't able to attend to the maintenance of issues such as a leaking roof. Then there was growing mold and other maintenance issues that were starting to, be possible that they might impact Lucinda's well-being. Mold, certainly an issue, especially if you have some breathing concerns. So when Miriam spoke to Lucinda's daughter, she was often met with resistance and arguing regarding what was an actual need for her mom. Miriam had consulted with several local community agencies, APS, as well as her supervisor, in hopes that the support systems in the area would be able to provide some kind of services to address the deteriorating conditions of Lucinda's home. But each time she was met with frustration and told that Lucinda didn't qualify for further action from any of those local agencies. Miriam began to lose sleep. She would lay awake at night worrying about Lucinda, kind of brainstorming, how can I help her? What can I do for her? To the point where she began to just dread going to care for her, because each time she would go, she would see something else that needed to be attended to and would have this big experience of just impending doom. What am I going to find today? And nobody will help, and I'm all alone in this. Knowing that those issues would have to go unattended because Miriam herself, that would be outside of her role. She also just wasn't capable of attending to them. She began getting angry and irritable with Lucinda, which, as you can imagine, impacted their relationship, started impacting Miriam's ability to provide good care for her, and caused a lot of problems within that situation. What Miriam found out when she went to talk to her supervisor is that she was experiencing some compassion fatigue. She had absorbed Lucinda's situation, her struggle, her disconnect from her family as her own, and had started having symptoms as if it were her own situation, her own trauma, and it started to impact patient care. That, again, is why it's so important to be aware of all of these things that happen in the work that we do so that we can attend to them as they come up or intervene if they're already there. When we're exposed to somebody's story, somebody's situation, I already mentioned we start creating images sometimes, we resonate with sounds, or we start asking ourselves and having conversations in our head like, what would it be like if that were my parent, if that were my partner, if that were my friend? Like, how would I feel? And then suddenly, again, we're internalizing it. We're making it as if it's our own. And that's assuming that it's not our own, right? We might have experiences where we have a parent or somebody in our family or somebody close to us who is experiencing or has experienced a similar situation. And then it complicates it because, again, this external experience is impacting us as if it were ours. What we often don't do, right, is assess our resources going in. We often are not stopping and being really purposeful and intentional about asking ourselves, what's going on for me? What am I carrying into this? What are all of the factors that are impacting me in the way that I see this? We need to intentionally recognize the impact of resource deficiencies in our environment. So maybe we're short-staffed, and I've been seeing, twice as many home health patients as I typically do because I'm covering for other people who have quit or are sick or whatever. Maybe we are short-staffed, in a long-term care. And so I'm working extra hours, or I'm not able to attend to things like I want to. I'm not able to spend as much time with the patients. I'm not able to engage in the relational components that are my warm fuzzies that build up my compassion satisfaction, because I'm just attending to the basic needs to make sure that nobody is in dire straits in the job. We need to pay attention to our own internal experience and know, where are we at? Am I getting enough sleep because I've been working extra shifts? Or am I tired and coming in with depleted resources the way it is? But if we're not being really purposeful and intentional about paying attention to the environment, our own internal experience, it's really hard to moderate it and then accurately adapt our thoughts around it. We have to assess ratio of supply versus demand, and we're going to talk about that here in just a second. This, I will try not to nerd out too much. I can get a little nerdy. But I show this because it's a model of compassion fatigue. It's one of the most prominent ones in research right now. And I feel like it's important to show, because compassion fatigue is not just, you know, something those of us in the touchy-feely professions made up. It is so prevalent that there is just a ton of research, a really objective research about what happens for people when compassion fatigue starts to occur. And so for those of you who are really research minded, I want your buy-in too, because it is a real thing that impacts us, and not only us. You know, ultimately it's impacting the people that we care for. And if you yourself isn't a motivation, I would imagine the people that you care for having the impact of your compassion fatigue is probably going to motivate you. So over here on the left, where it says resources, this is the supply and demand piece. What are we going in with? What do I have? What do I need? How am I entering into this space? Whatever your healthcare space is, what do I have available to me? Object resources. Those are those that have a physical presence, such as adequate staffing. Do we have medical supplies? Do we have beds? Do we have rooms? Do we even have a physical building? Do we have the things that we need to do our job? Conditioned resources. This is, how is my health? How is my spirituality? How is my mental health? How am I in my state going into this space? Do I have the capacity to have an attitude that allows me to give energy? Or do I have an attitude that's going to ask me to preserve energy because I'm feeling overwhelmed and burnout? Personal resources, those are the things that we acquire through learning and education, leadership ability, occupational skills. Do I have, you know, the skills to do my job? And then energy is literal physical energy. Where is my energy level? Am I working a lot? Am I sleeping? Am I attending to my nutrition? Or are those things really low and I'm already going in, you know, with half a battery, and I know that's going to deplete really fast. So before you go into your space where you're going to be giving some compassion and empathy, knowing, kind of doing a personal internal inventory of where am I at going into this space. Because as soon as you walk in, you're going to discover the second piece, which is the patient demands. Okay, you're going to discover what is needed from me today. And I'm going to guess sometimes you can adequately predict that, but sometimes you walk in and boom, you get hit with a truckload of really high demands. What I hear from a lot of folks, regardless of the healthcare area that they're in, is patient demands have increased over the last couple of years. People don't, basic needs are different, right? But safety is, if you think of Maslow's hierarchy of needs, safety is one of the very basic needs that humans have. And safety, whether that's physical safety, emotional safety, right? You know, can I trust my government? Can I not trust my government? Do I wear a mask? Do I not wear a mask? Are vaccines a thing? Are they not a thing? My doctor says this. Susie's doctor over here says this. Who do I trust? What does that look like? Right? Like the things, the systems that we used to rely on, now we question. Right? Before COVID, we never would have questioned our doctor, or maybe less frequently. And now people are saying, no, you don't know, right? I don't know if I could trust you either, because we're getting so many mixed messages. And so even systems that we felt comfortable to rely on disrupt our safety. And that increases patient demands because we have different needs now. And so we've got to know, where are we at? What are the patient demands? And then we do a resource appraisal. Do I have enough internal resources and environmental resources to meet the patient demands, or am I coming in a deficit? Okay. If I'm coming in a deficit, there's a threat. There's a threat to my internal resources. And what's going to happen is my brain, when I'm coming in a deficit, is going to say, I need to preserve. Okay. When my cell phone is at 30% and my kids come and say, hey, mom, can I play a game on your cell phone? I look at my battery and I say, nope, it's 30%. I need to preserve my battery so it functions through to the end of the day. Okay. If it's at 100%, I'm more likely to give it to them. That's what we're talking about here, is when we're coming in with a deficit that is lower in resources than our patient needs, we internally preserve, which means we don't engage in as much compassion. We don't engage in as much empathy, and it starts to impact our ability to accurately assess the needs of our patient, because we're going to want to under-assess, because to accurately assess is going to require something that we don't necessarily have. Okay. If we have more or equal to what our patients need, then there's no threat. And we can maintain our others focused. We can accurately assess needs, because it's not a threat to me if my patient has a more acute need today, because I have the capacity to manage that. Okay, so that's what we're talking about. That's the difference between compassionate care and uncompassionate care. And I'll leave the rest of it just for the sake of time. But the takeaway is, how do I intentionally pay attention to what I'm going in with and where that is in terms of patient demands, so that I can either find a way to ask for help and increase those resources so patient care doesn't become compromised and I engage in uncompassionate care. Or if I have extra, right, organizationally, I can identify where I can be of help for others who may be coming in with a deficit. Risk factors, I'm going to fly through these a little bit just because I want to have time to make sure that we get to what do you do about this. Not being self-aware, and this is a common issue. You know, we just don't pay attention to ourselves, especially as helpers in the health professions. We give, and are really stinky at attending to ourselves and our needs. You know, medical professionals all the time joke about, if you want to see the biggest people, the biggest group of people who smoke and eat out of vending machines, go and look at the health professionals at a hospital. Okay, that's a jokey stigma, and I recognize that. But the point is that most of us know, even though we're in the health field, we kind of stink at this stuff. We don't always stop, because it's our passion for people that drives us, and so we don't always stop to pay attention to what's helping or happening within ourselves. The other risk factors, that unconscious mirroring, you could play with this throughout the week. Pay attention to how much you do this with folks. Lack of our own resources. Maybe we're struggling financially. Maybe our support systems are low. Maybe we don't have access to the systems that we need. Our own personal history of trauma, if that's unresolved, that certainly impacts us, because we're going to pick up on those things a little more, because trauma begets trauma. When we already have trauma, we're more likely to interpret future events as traumatic, even if that's other people's trauma. And so it makes us a little spongier in terms of we're more likely to absorb that if we have our own personal history of trauma. If we don't have pretty solid, healthy boundaries, that is a risk factor. Some of us grow up just never learning positive coping mechanisms. And so if we don't feel like we've got a good tool bag of things to use to manage stress, that's going to impact us. Poor self-care, neglecting basics. You know, when's the last time I showered, washed my hair? Did I even eat today? I can't remember. Am I hydrated, etc. Environmental risk factors, working in an environment where you are repeatedly exposed to others' pain. You're in a health profession. That's going to happen on the daily, right? That the levels of what you're exposed to are going to vary, but that certainly puts you at risk. Increased demands that you don't have resources for, things that you can't control, short staffing, fuller beds, higher acuity of presenting, accreditation is a stressful thing for people, right? Other requirements. Lots of medical professionals are denied PTO because of short staffing, and so people aren't having time to step away and recover. A lack of resources or skills to engage effectively in the job. Another thing that I hear when I provide this training to medical professionals is, because we're short staffed, I just got thrown into the job and I'm learning on the job. That is a stressor. That is a resource sucker, because I don't feel confident. And when I don't feel confident, I'm not going to perceive those positive outcomes in the same way as if I'm feeling really confident and walking away from my job with increased compassion satisfaction. Inadequate positive feedback or outcomes, and then low collegial or supervisory support, because sometimes places are in survival mode and we don't have the opportunity to just connect and support one another in the way that maybe we'd like. Clues that risk factors are present, prioritizing others' needs. No, it's fine. I can do that for you. I can eat my lunch later, and then you never do. Or, yeah, I've worked, 3 extra shifts, but it's fine. I can sleep when I'm dead. I hear these jokes all the time, and I just think, oh gosh, compassion fatigue, we need to talk about that. Postponing normal time off, working on the weekends, or feeling guilty about taking that time. Or one thing I hear often is feeling angry or resentful towards coworkers. Like, how can she dare take time off and go on vacation for a whole week when we're all struggling? We're resentful towards others because they are engaging self-care, which is really a clue that we're not, and we probably need to. Working beyond the hours you're scheduled or paid for, skipping meals, not intentionally practicing skills that could help take care of you. So what can we do? There are, as I said, on that ProQual website, it goes much more in depth in some of these things, but I'm going to highlight a few. One is to educate yourself. We can't be intentional and purposeful about understanding what's happening for us if we don't understand that there's something happening for us and why that's a big deal. So you being here is part of that already. You're already educating yourself. Engage in self-care, set your boundaries, and increase your internal resources. Knowing your why creates motivation. Feeling stuck in a job demotivates us. So knowing your why do I choose to get up and go to this job every day? Why do I choose to engage in the things that I do? Even when there's a whole list of negative outcomes, because sometimes that also happens. Reminding ourselves intentionally, why am I here? Why do I choose to be here? What's my value that I'm linking the behavior of choosing to come into work to? Okay, and then we create our own positive outcome. It's not enough. We need those positive outcomes with our patients, but we create an internal sense of control, because here's my value, and I can link my behavior to that value and feel good about that, even if I'm not having very many positive outcomes with my patients right now. Self-care, this is a whole day topic in itself. Self-care is a buzzword, but few people really understand what self-care is all about. Self-care is 100% about self-esteem. It's about building those resources and determining that I am also worth it. You've heard probably a million times the example of, the airplane, if the mask fall, put yours on before you can put somebody else's on. That is so true and so poignant. If we are not purposefully attending to and resourcing ourselves, when we're making withdrawals out of our physical, emotional, mental bank accounts, we're going to be in the red really, really fast. And every time we allow ourselves to get in the red, we are sending ourselves the message, I don't matter as much as everybody else. It's got to be I matter, and therefore I take care of myself, because I have this value of helping others, and taking care of myself allows me also to link my behavior with that value. Self-care is not pleasing just to make conflict go away or to make other people happy and because that feels easier. Self-care, again, is about us and our internal wellness. It's not meeting superficial standards. It's not going home and having a bottle of wine at night. I'm not saying that can't be nice on occasion, but that is not self-care in and of itself. It's not zoning out or disconnecting or instant gratification. I talk about zoning versus recharging. In practice, one of the things we focus on is, what do you do for self-care? And more often than not, people will say, I binge out on Netflix or I play games on my phone. That is not recharging in most instances. That's zoning out. Zoning out allows us to disconnect. It's an escape. But when we come back from zoning, we say, oh my gosh, I feel terrible. I just spent 3 hours playing Candy Crush and I have all these things to do and now I feel worse. Recharging are activities that allow us to come out and say, man, I feel so much better. I'm so glad I did that. Again, with the cell phone example, if you have 30% on your cell phone and you just turn it off at night, when you turn it on in the morning, it's still going to be at 30%. It's not recharged. You have to plug it in. You have to intentionally give it something in order to replenish its battery. We have to intentionally give ourselves something in order to replenish our resources. Boundaries, also a whole presentation in and of itself. We stink at boundaries in this culture. We're not good at saying no, and we cannot be fully free to say yes until we learn to say no, because otherwise that yes comes out of obligation. If I can't say no, there's a different reason why I'm saying yes, and it's not because I'm really bought into saying yes. It's because I feel guilty, or I feel obligated, or something internally doesn't allow me to say no. So until we can learn to say no, it's really hard for us to give a healthy yes. Boundaries help set what is okay with us and what isn't. It gives us permission to be important and be well, and they're really, really important. And they're important for the people that we work with as well. Increasing your internal resources. Again, I know I'm flying through this. One of the things, if you are a sensory person, so you're hearing a story and you create an internal picture or sounds, or now you like have this whole thought out memory of what that was probably like for the patient who's telling you this story. If you are a sensory person who does that, that can be really problematic, because again, your brain isn't going to be able to differentiate that material. Right now, you've created a whole picture that you've never even seen yourself. So one of the things that can be really helpful is, if that's you, is when you are hearing stories, when you're attending to patients, seeing the impacts of whatever they're going through, is to find a way to contain the sensory narrative or picture that you're making in your head. One of the examples could be pulling a mental curtain. And so as you notice your mind making up pictures that go along with this, potentially traumatic story that your patient is telling you, you pull a curtain and let the images remain behind the curtain. It's imaginatory. However, what it's doing is helping your brain say, I don't need to create these pictures. I can hear, I can be empathetic, I can understand, but I don't need to create these pictures because I know what that does for me. Okay, so that's that internal awareness of what's happening for me and how do I manage it. Taking time for meditation, prayer, or mindfulness. We live in the future, we live in the past, we rarely live in this minute. The next time you take a shower, ask yourself, do I know if I washed my hair or not? Or was I thinking about the 80 things throughout my day and I don't actually even know if I washed my hair? Did I just eat that whole bag of cherries? I sure did, and I didn't even realize it. That's a really good clue. If things like that are happening to you, that you are living so much up here, this is an opportunity to be in the moment, to allow our minds to let go of all of the stress and use our senses then to be in our moments when we're outside of our patient care, to be with the people that we're with, to be in the space that we're with, take a walk and notice, what do you see, hear, smell, touch, taste. Learning to identify facts versus assumptions is another one. We create stories and narratives that are so made up all the time. We see situations, we hear things, we have conversations, and we walk away with this story of what that means for us or to us in our heads that are often filled with assumptions, but we are focusing on or acting on as facts. So learning to differentiate some of those things. Engage in gratitude. I won't nerd out here. There's a whole research bundle of how impactful gratitude can be on mental wellness. Find a source of meaning outside of work and find your people. A lot of us hang out with the people that we work with, which is great because I assume you work with really awesome people. And what do you do when you hang out with your work colleagues? Talk about work. Okay, yeah. So you've got to find a space. What else am I passionate about? How can I set this down? Move your body, tend to your basic needs. If you're holding a urination for a long time because you are too busy, that is a thing that I hear most often, actually. Like, go to the bathroom, make sure you're drinking water, make sure you're eating, make sure you're sleeping. Those things go off the table so quickly. And if our basic needs aren't intact, we can't do those higher level of functionings. So we've got to attend to our basic needs. Learn to relax. Many of us have no idea how to do that. Use humor, learn to laugh, seek therapy if you need some help. We are not just people who work with individuals who have mental illness. We work with people across the spectrum in self-development and overall wellness. Grieve your losses, celebrate successes, be pissed at systems if you need to, right? Get angry about that, share that, and then recognize what's in your control and what's not. Also, take time to intentionally celebrate the successes. There's a whole bit on culture as well. You all have access to that. And so I won't go into that because I want to leave a little bit of time for just thoughts or questions if you have any. So I want to open it up to whoever might have thoughts or questions.
I know for this group, I think you hit the head on the nail when you talk about running into issues with systems, and we talk about that a lot in our culture change group, that we, have patients that need something and we can't get it for them, or we run up against a family that doesn't recognize the need, or we go to our resources like Adult Protective Services and they say, well, they have food, they have a roof over their heads, they have whatever, and we're saying, but no, but this is not the way this person should be living. And so systems all the time in every level of care, and it does wear on you after a while because you just feel like you can't do what you need for your patient. And so I think that was very, very on point there.
Yeah, and if I could, you just said because you feel like you can't do what you need to for your patient. One of the processes of evaluating this, right, is sometimes we want to do more because we see more. And it's really helpful sometimes to recognize, where's my lane? Where is my scope? What am I able to affect? Where am I able to affect change? Where am I able to make a difference? Our minds naturally want to go to the things that we can't control, the barriers that we're running up against. And when we stay in spaces that are outside of our locus of control, the system spaces, for example, that is going to be what we see. And so reorienting to the facts, and here's where I can come in and affect change every day, because without the work that you do, I'm going to assume that that patient would probably, or patients would not be as well off as they are. Having someone in there seeing those things, caring about those things, advocating, whether you can control those systems or not, makes a difference. And so when I say celebrate the successes or intentionally be recognizing some of these spaces, it's a mind shift from what we can't affect to where are we affecting? Because my value is to help in the way that I can, and I can't be responsible for all of these systems, but I can shift my mind to allow me to be in the space where I can affect change. And it doesn't mean that it's always going to feel enough, but it helps you recognize the positive outcomes of the work that you are doing and the impact that you can have. Because that is frustrating. Yeah.
I think Anna wanted to say something.
Oh gosh, many things. This presentation was dynamic. I loved everything about it. I think you as a presenter, Dr. Sarah, you are just amazing.
Oh, thank you.
And the way that we can connect to this learning, because I don't know, for me personally, I was feeding off your energy and your passion on it. I'm just being honest. It was
Yeah,
just
I appreciate that.
fantastic. A couple of key things though, because I'm boots on the ground in long-term care, is I loved your signs and symptoms grids that you had. We can take that for us.
Yeah.
I, as a nurse especially, I can apply that into practice. You know, I know you understand what I'm saying, is to have those simple visuals. The other thing is, I didn't know like there was an unconscious empathy. And I start thinking, oh my goodness, is this me? You know, you start your own self-reflection on this. The other thing is your words are descriptive. And I liked how you said personal inventory, resource appraisal. I really liked, and I made note, emotional bank account. And I really highlighted, like, are you in the red? I'm thinking, in the red? I was doing this whole self, but everything about this content, I thank you. I know we're short on time, but I thank you. And I strongly encourage you. I'm going to bring this up to Nebraska Healthcare and American Healthcare Association. I think this is something we desperately need, but you put a different, not twist, a different spin on it, that it's not just defining it. You went into a deeper dive. How can you actually take this and put it into practice? Thank you.
Yeah, my pleasure, and I appreciate that you're recognizing the value of it. I am passionate because I see it, right, and I've been there. I get it. And I just think, gosh, what is this going to look like when we continue to have folks in healthcare burning out and changing professions because we're not doing adequate support for the people who are carrying so much, right? And there's a huge trickle down from that that ultimately impacts the most vulnerable. And so I appreciate you recognizing the value of this information, because it is really important, and it's also possible to shift and change it if we can have that awareness. Yeah, thank you.
And I think you just said a key word there. It is possible.
Yeah.
It's not like something is preventing us from doing this. It's, yeah, this is good. We need it.
Good. Thank you.
I'll make a comment. I'm not in healthcare. I simply saw this and was curious, and
I just realized who you are.
Yeah, hi. But I just needed to let you know that this is incredibly applicable to me, even though I'm not in the healthcare field. I mean, I'm probably an empath by trade. And so, and my mother has recently just required some extra care. So in that way, I can certainly apply it. But I can actually sit here, even in my job, I'm sitting at the airport in aviation. I can technically apply all of these concepts to my job, my home life, my, personal relationships. So, really good presentation, Sarah. Thank you.
Yeah. Thank you. Thanks for joining in.
And I think, Stacy, you make a good point there. This is across all industries, all human life. This isn't just one population, one type of service. It's just great.
Anybody else have any other comments? Well, thanks for joining us today. Please don't forget to go and fill out the survey. That's how Sarah is able to utilize the grant money that is providing this presentation for us. So please go online and do that. And make sure you join us next month for our Coffee with Coalition. We'll be getting information out about that. Sarah, thank you so much for
My
your
pleasure.
presentation today. And if you guys have any questions, reach out and let us know. But we appreciate you being on here today.
Thanks, everyone.
Have a good one. Thank you.